Good evening, everyone. On behalf of NASH 24/7, I welcome you to our public awareness program on management of fatty liver. NASH 24/7 aspires to bring best in class education and awareness program to serve healthcare workers, patients, and their caregivers. Today, we have a renowned gastroenterologist from Chennai, Dr. Vamsidhar Reddy. He needs no introduction, however, I would fail my duty if I don't mention that. Dr. Vamsidhar is a leading gastro in Chennai, providing comprehensive and compassionate care to many patients for various gastrointestinal and liver conditions. He has experience building a clinical skill set that allows him to deliver patient centric care. He is currently associated with Apollo Hospitals as consultant hepatobiliary pancreatologist and liver transplant physician. Sir, we salute your dedication towards spreading awareness related to liver health. So now I invite Dr. Reddy to enlighten us on the topic. Over to you, sir.
Hello, good evening, all. I first thank you for the opportunity given by the JIDS people and for the kind introduction given by Rahul. And I am privileged here to be here today among all of you to show some knowledge which I gained through my residency and also during the clinical practice on the management of fatty liver. And I bring greetings from the Apollo Hospital, Chennai. And I am currently working as a consultant hepatology and liver transplant physician in Apollo Hospital, Chennai. So I will be next dealing with the management of fatty liver for the next 30 minutes or so. Coming to first slide, so we should know about what is liver. So liver is the second largest organ of the human body, and this is the first largest internal organ in the human body, and is the second largest organ of human body. The first being the skin, and so it's around weighing around 1500 grams, and it is located in the upper right hand portion of the abdominal cavity. Generally, the liver is So generally, the liver is located in the right upper side of the abdomen, and which is generally will have a brown in color and soft in consistency, and which is highly vascular. It is a unique blood supply, being having two blood supply as the name suggests, and it was one from the hepatic artery, which is from the directly from the heart. It will receive the blood. This is the oxygenated blood, and the vein, portal vein, which is the biggest vein, so which brings the absorbed nutrients from the intestines, so which is helpful for the energy metabolism and the metabolism and the energy production and further activities what is occurring through the liver. And this liver is called warehouse of the liver and is also powerhouse of the liver. It almost consists of 500 functions. So the main functions are, it is a detoxifying organ, so it removes the potentially toxic byproducts of certain medications, and it also prevents the shortage of the nutrients by storing the vitamins like vitamin A, D, E, K, and also it is also helpful in the metabolization of the nutrients to produce energy, which is when required during starvation or routine purposes. And it is also produce the most important substances called proteins, which is required for the body, and is also useful for the producing the immunity, so that it can fight up against the whatever foreign organisms, and also fight against removing the bacteria from the blood. And it also helpful in the most of the clotting factors are produced from the liver, so it is helpful in the blood homeostasis. And already said, it is helpful in the digestion of the fat, which is also useful for the absorption of ADEK. Coming to burden of liver disease in India, I think recently the Minister of Health Welfare has included this fatty liver disease in one of their national programs as a one of the non-communicable disease in India, and it's a great initiative from the government to help both in to keep fatty liver in the notion, and also helping in the funding for research, and also helpful for in the further propaganda and prevention of the fatty liver diseases. And and chronic liver disease, which is a further spectrum of the fatty liver disease, which will occur in the last stages of liver, and is a public health priority in India, and it contributes about 18.3% of the total 2 million global liver disease, which has been mortality which has been occurred. Among them, is 18.3% is due to cirrhosis of liver. And if you see, there was a substantial increase for every year the death per million is increasing. As if in 2016 it was around 200 million 200 deaths per million are occurring in all over the world. And coming to there's a two diseases are there. One is non-alcoholic fatty liver disease and alcoholic liver disease, which are emerging as important causes of cirrhosis of liver in the country. So due to the changing in the Western, changing and adoption as a Western lifestyle, and also uh, adopting the social customs, now the fatty liver disease has been increasing. And hepatitis B and C currently are the major cause of CLD, and in the few years, I think fatty liver disease will take out that position and being the most important cause of the chronic liver disease in India. Coming to prevalence of fatty liver disease, so if you see here, so 1 out of the 4 people have a fatty liver disease, regardless of the weight. So in some places, it will increase to 50% in the places of like Chandigarh in the northern parts of India. So it's almost a study says that it's around 50% have fatty liver. And if you and these diabetes and obesity are interplayable with fatty liver disease. So more than 6 diabetics means like in a patient of 10 diabetics, if you take so out of that the 6 patients will have a fatty liver disease. And also in 9 severe obese people, severe obese means his BMI is more than 35. So there 90% of the patients will have a fatty liver disease, like 9 out of 10 patients. And male gender is regarded as a risk factor for progression of NASH and into the fibrosis. And you know the fatty liver disease is not a single spectrum of disease, and it is not a single disease. It goes into a gradual progression into further stages. So it's called a spectrum of liver disease. So like generally as a liver disease per se, there will be some acute component, chronic component, and the final stage is called cirrhosis. In the cirrhosis, there will be decompensated cirrhosis, compensated cirrhosis, and acute and chronic liver failure. Chronic hepatitis, generally autoimmune hepatitis, which generally occur in females, which is due to destruction of hepatic cells due to the autoimmunity. So this is autoimmune flare or hepatitis B flare can occur in this chronic hepatitis stage. And acute hepatitis is generally rare. It is caused by most common by hepatitis A and E, and which in turn some patients, very less patients will turn into acute liver failure also. So these are the common symptoms patient can present with. Patient can have jaundice. Patient can these are the blue color columns which are seen. So these are the in the esophagus, basically in the food pipe. So these are the esophageal varices. So these are if they burst out, so they can have the massive upper J bleed. And if then sometimes patients will have a hematochezia, which is called bleeding to the rectum, and patient will have abdominal distension. So this is called ascites in the medical language, and there is called encephalopathy, which is a confusion and altered sensorium in the patients. And the final stage is called liver cancer. So now the fatty liver is called emerging epidemic. Now we can say it is going through a stage called pandemic also. So this as evolution of man going on, and due to the adoption of the sedentary lifestyles and also increased westernization of the diet and also increased aerated drinks, the as the evolution grows, actually the fatty liver also grows. And I wanted to have a discussion about 2 slides regarding the newer nomenclature. Previously, it is called a non-alcoholic fatty liver disease. Now it has been changed. There were 2 amendations has been done. So first, they have told us a metabolic associated fatty liver disease with some specific criteria like patients should have an obesity or overweight or type 2 diabetes mellitus with at least 2 of the metabolic risk abnormalities like waist circumference, blood pressure more than 130 by 85, and triglycerides of more than 150 with HDL of less than 40 for men and less than 50 for women should be there. If it is more than that, we will take as a risk factors. And patient having pre-diabetes or having diabetes and the HOMA score should be more than 2.5, and a high sensitive CRP protein should be more than 2 milligrams. Any of the 2 metabolic risk abnormalities, we will note it as a metabolic dysfunction associated fatty liver disease. And after that, in 2023, there was a domination done by ASLD group. And now it is called as a umbrella group. It is called steatotic liver disease. In that, there's this due to this metabolic dysfunction associated steatotic liver disease called MASLD, and the one is called as meta-LD. Meta-LD is which are the subgroup of patients which have both fatty liver disease and also having a increased alcohol intake. Here, the increased alcohol intake means generally the safe limits of alcohol is more than 2 drinks for men per day, and more than 1 drink per day in women. So it counts to more than 14 drinks per week and in men, and more than 7 drinks per week in women. So if the patient is taking more than this 14 or 7 according to the gender status, and the patient is also having metabolic risk factors, then we have to label them as metabolic ALD. And one set of patients is a pure ALD, like patients will not have metabolic risk factors, and patients only have the steatotic liver disease due to alcohol. And there's another group called specific etiology group, like a patient who have consumed drug induced liver injury, like who consumes Ayurvedic, homeopathic medications, or some estrogens or steroids. They'll have this drug induced liver injury. So this is a specific etiology SLD. And monotonic disease, like some genetic disease and some miscellaneous uh, components also can cause a specific etiology CLA, like hepatitis B, hepatitis C virus. And cryptogenic, if we don't know the cause, so then we label them as cryptogenic SLD. So if you can see, this is the healthy liver, and this is the brown regular margins will be there. And if you see the fatty liver, the healthy liver will be consisting of less than 5% of the hepatocytes, less than 5% of the fat in the hepatocytes. If it is more than 5% of fat in the all hepatocytes, then it will be calling a labeling as a fatty liver. And as I told you, if the cells, whatever the liver hepatocytes are there, if they accumulate fat in the liver cells, it is called fatty liver, or steatotic liver disease. And if it is liver cells are getting ruptured due to the injury caused by the fat, then and when there's a LFT abnormality, then the stage is called non-alcoholic steatohepatitis. And if it's further progress, there will be fibrosis and scar formation, which is called cirrhosis. And if it's further grows, patients will be having decompensated cirrhosis and further development of hepatocellular carcinoma. So this is what is left, and if we left untreated the steatotic liver disease at the initial onset itself, it can progress into NASH. So being overweight or obese and patient having high type 2 diabetes or high cholesterol or triglyceride levels are associated with increased risk of NAFLD. So this I've told, see already I've mentioned about this thing. So this is a spectrum of fatty liver. So this is a healthy liver where there will be less than 5% of fat, less than 5% of hepatocytes will have fat. If it is more than 5% hepatocytes have fat, then it is called non-alcoholic fatty liver disease. And then further progression to NASH and cirrhosis and hepatocellular carcinoma. If you see the percentage, say among 15 to 30%, they will develop into fatty liver disease. Now that percentage has been increased now. So now in that 15 to 30%, 12 to 25% will develop into NASH. In that, again, the 1/4 of quarter patients can develop into cirrhosis. In that, again, around 5 to 7% can develop into hepatocellular carcinoma, which further lead to liver transplant or mortality. So if we have a population of 138 crores as in India, so it is around 45 crores of people will have a fatty liver disease. You can now I can understand the how much is the burden of the fatty liver disease in India. And with 14 crores, among the one third of the patients will have a non-alcoholic steatohepatitis. That means the patient will have a liver injury due to the rupture of the cells or injury to the cells caused by the uh, fat. And then coming to cirrhosis, in that around 1/4 of the patients will develop cirrhosis. So 3 crores population. In the now currently, if you see in India, the prevalence of HCC will be around 21 lakhs. So that too due to hepatocellular carcinoma, due to the fatty liver itself. So this is the histology of the fatty liver. If you see, this is the normal architecture of the pink color HNE stain which is seen. So this will in turn develop into the fat globules. So this is called a fat. This white color is called the steatotic globules. So then further there will be a lot of inflammation. This blue color things are called inflammation because cells are being ruptured, and it is called active hepatitis. It's called the non-alcoholic steatohepatitis. And further it will be changing to this blue color thing is called fibrosis, and it will be liver will be hard. If you see the live example, this patient is a living liver transplant donor, and this patient liver transplant recipient. so which has recently occurred. So in this, you see there's a liver is nodular, irregular architecture is there. But if you see the donor liver, which is a healthy liver, you see the pinkish regular border liver. This is a healthy liver. So, and fatty liver is a multi-system disease. So, like it is not a single if a fatty liver disease will not be sitting silently, it will be gradually progressing to all the other diseases due to the risk factors what they're having, like diabetes and also hypertension and obesity and high triglyceride levels. So, which will cause patients will have polycystic ovarian, females will have polycystic ovaries, and patient will have diabetes, and that itself will produce a sleep apnea due to obesity, and kidney disease and heart disease can develop among it. And some patients finally land up in hepatocellular carcinomas. So if you see this data, so among the patients who are having liver transplant candidates, so 13% of the whole liver, due to all the etiologies, the fatty liver, due to non-alcoholic fatty liver disease, it is up to 13% in 2005. Now it is by 2020, the data sources has been tripled. So 39, 40, around 40% are the LLE who are the liver transplant candidates. So who are the now coming to who are the people at risk of NAFLD? So it's the diabetes, obesity, hypertension, and high cholesterol, hypothyroidism, and the genetic. Now there's a now the research is saying that there is genetic predisposition, that means like a fatty liver will be prevalent in all the family members also. So we have to screen them and we have to counsel them for the reduction of the injuries for happening due to the fatty liver, and then we have to maintain him in the fatty liver stage, or we have to get him to the healthy liver so that it will not go into the other further stages of the further liver damage. And physical inactivity, all these things are the risk factors for the fatty liver disease. So and fatty liver disease and diabetes is bidirectional. If you see, there were threefold increase in risk of death due to cirrhosis, and due to increased risk of NASH. And this NASH fatty liver will go into diabetes, and diabetes itself will again increase risk of NASH. NASH will again develop into cirrhosis. So even if there is a high prevalence of diabetes, 2 to 4-fold increased risk of developing in diabetes. In the patients of fatty liver, the diabetes incidence also increase. In a patients of diabetes, the fatty liver incidence also will be increased. So that's why it is called bidirectional. And coming to symptoms of fatty liver disease, initially the patient will usually will not have any symptoms. The fatty liver may be detected like as a incidentally, like if they go for any other problem to the physician, they'll do an ultrasound, suddenly the fatty liver will be detected. Or maybe they do a liver function test as a master health checkup, in that they will be finding that so the SGOT, SGPT are altered, and then further evaluation they'll be knowing that they are having a fatty liver disease. In few patients, like 15 to 20% of patients, they develop some symptoms like fatigue and right upper abdominal pain, and some discomfort in abdominal pain due to stretching of the capsule around the liver, which is called Glisson capsule, and nausea, some nausea will be there. And some patients, if they develop cirrhosis, like from the NASH, it has gone to cirrhosis, then patient will have a buildup of the fluid in the abdomen, which is called ascites, and patient have hepatic encephalopathy, which is called confusion, irritability, and final stage they can go into coma also. And a decreased loss of appetite patient will be having, and all the body like surfaces, so there will be easy bruising or ecchymosis due to the low platelet count, and patients will also have a swelling of the lower limbs, which is pedal edema, and there will be some weight loss if they develop any liver cancers, and due to cirrhosis itself, due to sarcopenia, patient will have unexplained weight loss. And there was also a yellowish discoloration of eyes, and also patient will have vomiting of blood, which is called hematemesis, or through the stools they will be they'll have blood in the stools, so that is called hematochezia. And I have touched on like now etiology, epidemiology, and also risk factors, and now clinical features are completed. Now coming to how to diagnose fatty liver disease. The fatty liver disease is a silent killer because progression of disease is always gradual. Because once a patient develops fatty liver disease, it takes almost 5 to 10 years generally to develop into cirrhosis or NASH stage. So generally, it will not be asymptomatic generally most of the patients. So it is like a silent killer, because if you are not going to the hepatologist for the further treatment or further precautions what to be done for that, so it will be going silently, it will be progressing into the further stages and and patient will land up in complications of the cirrhosis to the hospitals. So the diagnosis of fatty liver often involves the following. So it involves some simple blood tests, and there is a through radiology scans like ultrasound scan and non-invasive marker, which is a new one which is coming, is called fibroscan. And some patients will require liver biopsy for pathology for confirming the diagnosis. And very in research purpose, will be using MRI and CT abdomen to know the fat fractions. So that I will be dealing in the further slides. So the simple blood test, what we will be doing is liver function test. In that, the most important is AST and ALT, aspartate transaminase and alanine transaminase. So this is the most important, which is a marker of the liver injury. So if the fat and oxidative radicals are increased due to fat deposition, then the cells will be rupturing and then causing the increase in the elevation of these enzymes. So this is a measured as a part of the liver function test. And one first test generally we'll do after this test, we'll be doing the fatty. We'll go for the ultrasound. And some patients will directly incidentally do an ultrasound for some other problem. They develop, they have a fatty liver, and then the first test used to be done is the AST and ALT. So if the patient is having these enzymes are elevated, then this will be the patients will be called as a non-alcoholic steatohepatitis and is associated with the disease progression. Patients with normal ALT also can have this disease progression, but to the lesser extent compared to the patients who are the patients who are having the increased enzymes. So, and most of the patients of fatty liver, plain fatty liver disease, they will not have a abnormal LFTs or ALT and AST levels. But other 20% can of the normal fatty liver disease can have the AST, ALT enzyme elevation also. So, and there's no cutoffs for the prediction of the NASH and advanced fibrosis in FLD patients for currently. So coming to non-invasive scores based on this simple blood test like a hemoglobin, like a CBC. Basically, in that we see the platelet count. There are two, three scores which have been used for the prognostication of the NASH. So one is FIB-4 score. We include the simple online calculator which will be using AST, ALT, and platelet count, and we'll be dealing with the cutoffs. We'll be dealing with whether patient requires further evaluation for the management. And there's a one more score, NFS score, the NAFL fibrosis score, which includes all these parameters plus body mass index, fasting glucose, and albumin. There are other online tools like FAST score, which is the fibrosis plus AST score in the recent one, and also AJLI scores. And these are the new scores which have been available. Coming to radiological investigations, ultrasound. So if you see this ultrasound, this is a normal liver. So it is these are the and this is the homogeneous echo texture of the liver, and this is the borders of the liver. So nicely it is demarcated. If you see the fatty liver, it is like a slightly bright in color compared to this dark color, and this liver will be enlarged slightly. If you see the cirrhotic liver, and this black portion is called ascites, which is the abdominal fluid collection, and the liver itself will become short, size will be decreased. Then the margins, if you see these irregular margins, it is called cirrhotic liver. So this ultrasound, what are the advantages, is easily available and first line of test for the fatty liver, and the first radiological investigation will be doing, and is economical, and it is available in everywhere, and is a reason for most accidental diagnosis of fatty liver. And but only thing is at least the fat should be more than 25% for the diagnosing of the fatty liver by ultrasound. But that gray area of 5 to 25% will require some other non-invasive diagnostic markers, so that I'll be dealing in the further slides, and it will not be differentiating between the fat and the fibrosis. So this is the newer technique called fibroscan, which is the principle of transient elastography. So here the ultrasound, this is the ultrasound probe, and there will be M probe and XL probe according to the BMI of the patients. So now this we'll be placing this in the near the right side of the abdomen and we'll check the intercostal spaces, and we'll put the probe and we'll be generating the pulses. So then the vibrations will go and reflect back into the means it will go into liver and reflect back. Based on the velocity generated, the report given will be having two components. One is a liver stiffness measurement, which is the degree of fibrosis in the liver, and which whether liver how is the liver functioning will be knowing. And one is a control attenuation parameter, which indicates the degree of steatosis in the liver. So this indicates the how much amount of fat in the liver, and there will be grades S1, S2, S3 will be there. Based on that, less than 33%, 33 to 66%, and more than 66% of the hepatocytes, whether they are affected with the fat or not, will be knowing according to the grades of the cap value. So the general fibroscan report will come like this. So if you see the cap value is 190, so that means the patient is not having a fatty liver. It's more than 245. So 245 to 260, it is S1, which is steatosis 1, and steatosis 2 will be from 260 to 290, and if it's more than 290, it is called S3. And the fibroscan also is the same thing. Basically, if it's less than 7.1, so it is called F0 F1 fibrosis. If it's more than that, F2, F3, F4 will be there. If more than 12.5, we'll call as a means means it is called F4 fibrosis. So based on that, we'll be quantifying the amount of fibrosis in the liver, and also we'll be quantifying the amount of steatosis in the liver. So this, what are the pros in this is diagnosing NAFLD with fat more than even 10% also will be diagnosing it, and it will differentiate between fibrous and the fat content. It is easy to operate also, but only thing the cons is basically it is not available freely currently, but now almost bigger hospitals are all having the fibroscan. And the one major thing is in the obese patient or patient already having fluid in the abdomen, will be having the misinterpretation. But obese patients, we have a new probes which is called Excel probes. I think 60 to 70% of the problems has been taken care by that probes, and rest is still 15 to 20% will have that intra-observed variability, and inter-observed variability will be there. So that requires further evaluation, further technological requirements are required in future. And the further, if you go in the research hospitals or research college, research medical colleges, they're using MRI fat estimation, and patients and hospitals which are having the liver transplant, they'll have this MRI PDFF, so which will estimate the fat fraction. Only advantage is it will estimate whole of the liver, because in the fibroscan it is only region of interest will take only shorter area, but here whole of the liver will be analyzed by specific programming, and then we'll be knowing the fat fraction. So it is a gold standard to detect fat fraction in a non-invasive methods, and it can measure fat fraction even more than 1% also, as compared to fibroscan, which is more than 10%. And it is widely used for liver donor patients, like in all liver transplant patients. In the liver donors, we'll use MRPDFF to know the fat fraction. It should be in the positive value to whether to go further, because if it is a positive value, then that means the patients are fit for donation of the liver, and the hepatectomy donor hepatectomy can be done. If it is less than, if it is negative values are there, then we have to further do the biopsies, and then only we have to go for further uh, evaluation of the donor. And but only con is it is costly, and also is not widely available. And coming to invasive method, liver biopsy, and liver biopsy will do in a very specific set of patients. As a fatty liver per se will not do liver biopsy, but it is a golden standard method for diagnosing fatty liver disease. But only when we used to do only for mainly for research purposes, and also second one is when we have a concurrent etiologies, like patient also will have hepatitis B and C, and patient also have metabolic factors. Will not be knowing why the AST, ALT levels are elevated. In some patients, we'll be doing to rule out other liver disease. We need to know, we need to do the liver biopsy. But other cons are like it's slightly painful, invasive procedure, and there's some percent of risk of bleeding will be there. But in this also the same thing as fibroscan, will be taking into only very small part of liver. Basically, whole liver, that part may be the fatty liver will be there, pick up the so other part may not be fatty. So that is the disadvantage from the liver biopsy. So coming to prevention of fatty liver, so prevention is the best way to treat fatty liver disease. The first thing is maintain ideal body weight. So what is the ideal body weight? For simple terminology, we'll do as a height in centimeters minus 100. If the patient is 170 centimeters, the ideal body weight should be 70 kgs. So this is a simple formula everybody has to use so to know the ideal body weight. So healthy eating, so avoiding the aerated drinks, avoiding the fried items, avoiding the red meat. So all these things is a healthy eating, and no alcohol limit or intake within the safe limits. So problem is that, see, if the patient is already having a fatty liver disease or any liver disease, the patient should absolutely stop alcohol. No ounce of alcohol should be taken by the patient. But if the patient is having a normal liver, they should know the what is the safe limits of alcohol. As I mentioned previously in the slides, like it is more than 2 drinks per day. That means like one drink is equal to around 30 ml of, if you take as a whiskey as a this thing. So 30 ml of whiskey consists of around 10 grams of alcohol. So that means that 2 drinks has to be taken per day, which is a safe limit of alcohol. If the in clause in brackets, it should be patient should be having a normal liver. If a normal liver is not there, absolutely no alcohol for the patient. And patient has should do a regular exercise and annual healthy screening for early detection. And we cannot do for all the person, but who are having the risk factors, more than 2 or more risk factors are there, then we have to do a healthy health screening, including the liver package. So we have to do all the test which is required for the liver as a screening test. At least the minimum basic things should be complete blood count, liver function test, hepatitis B, hepatitis C, and ultrasound abdomen, and lipid profile, and fasting blood sugar. These are the 5 to 6 blood tests which minimally has to there in the health package. So to know the status of the liver disease. So the next question comes, which is what is a healthy light? What is good for the liver? So it is the like leafy vegetables like broccoli, cauliflower, and beetroot, and leafy green vegetables, and citrus fruits, which is antioxidants, and egg and fish. Egg is the highest protein available in currently, and fish which have omega-3 fatty acids. These are all the proteinaceous foods, and walnuts is the all the dry fruits including walnuts, and garlic and coffee here. At least 2 drinks of coffee per day is good for the liver. Which is not good for the liver is sugar, salt, and 3S will tell the sugar, salt, and saturated fat. And in that alcohol anyway, and the aerated drinks, whatever all the aerated drinks, so it has to be stopped. And because it will have a high amount of sugar, and which is in turn will be bad for the liver. And the baked items, storage products, bread, biscuits, and French fries, all the burgers and pizza, and mainly red meat and excessive. All these things, foods are not good for the liver. And who needs treatment for the fatty liver? Treatment actually has to be indicated in some specific set of patients. That's why we all the patients who are having diagnosed with fatty liver, they have to be consulting a hepatologist for further what is the preventive measure they have to know, what is the type of diet what they have to know, and what type of exercise they have to do, and how to, if there is some specific set of patients that we'll be knowing according to the test done. So based on that, we have to treat with some of the fatty liver, some of the medications that reduce the fatty liver, and also the further spectrum of liver diseases. So that treatment should be indicated in progressive NASH, like a patient having AST and ALT, and there was some increased fibrosis in the fibroscan, or the increased grades of fatty liver. So we have to go for the treatment based on the as we have to see as a, not only we have to see as a patient as a comprehensive approach, we have to see based on that we have to give the treatment. So early stage of NASH with the risk of fibrosis progression, like high ALT, diabetes, age more than 50 years, or the metabolic syndrome. I told like what are the four things in the previous slides. So they are that constitutes of metabolic. So these patients are there. So to if the patient having a fibrosis progression are there, then we have to treat the patients accordingly. And the patients who are having, if the patient have done the biopsy, then if they're having a high necroinflammatory activity, and the patients with having active NASH, so they have to be treated. And anyway, the patient already developed the NASH-related liver cirrhosis, and the patient who had HCC, hepatocellular carcinoma, is a liver cancer in the fatty liver patient, and that patient has to be by default has to be treated. So the treatment of fatty liver, which will go in with three-fourths. This is a summary of the slide actually. So the diet, if you see that is leafy vegetables and the fruits and vegetables should be the part of the main part of the diet, and around 50% of the diet should be having this fruits and vegetables, and 25% should have the carbohydrates and like cereals. and other 25% should be having the protein diet. So that diet, which and olive oil is the best oil, which currently according to Mediterranean diet. So the Mediterranean diet is the currently the better diet for the fatty liver disease. And the exercises we can do that both aerobic and resistant exercises, which is good for the cardioprotective exercise, which is good for the liver, and also as a systemically good for the reducing the hypertension, reducing the diabetes, and also further reducing the cardiovascular diseases. And lifestyle modification: no alcohol, no smoking, and in decreasing the sedentary lifestyle. So these are the things which are do. And some patients will require medications for high cholesterol levels or high triglycerides and control of the diabetes and fatty liver per se. There are 3 4 medications which has come into the market and which have specific indications which are endorsed by the Indian INASL group. So that medications will come in the next slides. So, but nothing can be without any consulting any doctor about fatty livers. We should not be directly going. All patients should not be starting on medications. So there will be some specific indications for starting in medications in fatty liver disease. So consult an hepatologist for the further doubts, including clearer doubts and further progression and prognosis of the fatty liver disease in the future. So which diet to follow? So generally, as a notion, we generally tell 500 to 750 kilocalories. Generally, we all eat 2000 kilocalories according to the ideal body weight. Around 60 to 70 kilo person we have to eat around 2000 kilocalories per day, with around 1 gram per kg per protein has to take per day. So 60 grams patient, so 60 kgs patient has to take 2000 kilocalories with 60 grams protein. But if the patient has a overweight, so then the overweight or obese, so the patient has to take reduce the diet, reduce the calories by 500 to 750 kilocalories per day. And balanced Indian diet is good, like 20 like Indian diet consists of like 50% will be carbohydrates, 25% will be fat, and 25% will be proteins. That we have to slightly modify and make it the 25% only carbohydrates, and 50% we have to increase to the leafy vegetables and fruits, so that automatically the calories intake will be decreased. And high protein diet, so protein, so like egg, protein there is no restrictions, like egg and fish can be taken. And avoid refrying oil. And in Indian scenario, it is the most common thing we'll using one of the same oil we'll be using second day, third day, so the saturated fatty acids will increase by this. So we have to avoid the refrying oil, and we have to cut out the sugars from your diet as far as possible. And I told already that coffee is good for this. It's not is 2 cups of coffee, but it's not the routine coffee with milk and also sugar, 2 spoons of sugar, all these things. So it is a black coffee without milk and without sugar. That's good for the liver. So if this is the diet chart, generally if you see the daily consumption, the green color, it is the daily consumption. Weekly color in the slightly orange color, and biscuit color, and this 1 to 4, this monthly color in light pink color. So if you see that most of the things like I said, milk, cheese or yogurt, olive oil, fruits and nuts, and this if you see here, it is uh, 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 this potatoes, legumes, vegetables, all these things should be daily consumption should be done. If it comes to the poultry or eggs or fish, it should be a weekly, and the sweets also to be. The red meat you have to avoid, like maybe 1 to 4 sessions in a month, like that it should be there. So the major chunk of the diet we should be consisting of the vegetarian predominant diet. And coffee and fatty liver, I already told 2 cups of coffee, but I am again mentioning this is not a routine coffee, it is a black coffee. So coming to exercises, so I already mentioned in the previous slides is the aerobic exercises and resistance exercises. So it reduces liver fat, maintains the healthy weight, and improves the cardiovascular conditioning. And resistant exercises reduce the liver inflammation, improves the metabolic parameters with less energy consumption. So aerobic exercise includes I generally prefer to telling the patients is running and cycling. If the people know swimming, they can do it according to their time. So running and cycling are the good exercise for the patients. And resistance exercise like weightlifting if they are having dumbbells in the home, and at least 150 minutes a walk. Some people will take tell the 250 minutes in a week. So at least the minimum should be 150 minutes a week. So 30 minutes per day for 5 days in a week is the minimum criteria for doing exercise. And if you have a counting a steps like that, so at least a minimum of 10,000 steps a day should be there. And it should not be. And the main problem with the patients is so they will be hurry to reduce the body weight. So doctor has told us, and they will be doing hurry. So these patients cannot sustain the weight loss. They'll do maybe within one month they'll do they'll decrease to 3 to 4 kgs, and later again they'll be gaining the weight. So we have to do in a gradual manner, and we have to be programmed everything in every monthly or every weekly, how according to their status, and then they have to reduce the weight. And how much to reduce the weight, I'll be coming to next slides. And whenever you have a states, please use the states whenever possible. And this is the weight chart, how much. So generally we use generally we tell that if the patient have a NASH, all these things, so weight loss of more than 10%, it is the best thing. So if you aim for high, at least if you reduce to 7 to 5% also, actually there was a lot of things which is happening in the, which a lot of things which is happening in the liver, and it will be reversible. So fatty liver and also non-alcoholic steatohepatitis, these are reversible if you diagnose in early. But if the patients go into cirrhosis and liver failure, and also as a hepatocellular carcinomas and or advanced fibrosis, it cannot be reversible, and it is done and said that it is irreversible disease. So the main criteria of this lecture or the Zydus initiative is we have to screen the patients, and we have to find the patients in the NAFLD or in the non-alcoholic steatohepatitis range, and we have to reverse the patients to come back to the normal healthy liver. So if we aim at high, and then we can be reducing at least 5 to 7% weight loss is also there, it is okay. But the patient is having advanced fibrosis, then we have to go for weight loss of more than 10%. So summary for the management, I already told, is saturated fats and trans fat. We have to limited intake of these things we have to do, and eat a balanced diet, including all the leafy vegetables, fruits, and reducing the aerated drinks and reducing the fried items, and limit the consumption of refined carbohydrates, and maintain a healthy weight. What I told is a height minus 100 centimeter, height in centimeters minus 100, and quit smoking, exercise regularly, the 150 minutes per day, and limit or avoid alcohol, and take medications as prescribed. So the medications actually, what are the three? Currently, INASL has endorsed, INASL Society has endorsed the three medications like saroglitazar and vitamin E and pioglitazone. So based on the specific indications, we'll be giving the medications at least for 1 to 2 years. We'll be giving according to the indications. So all the patients has to be screened, all the who are having the risk factors, and once they are diagnosed with fatty liver disease, please consult an hepatologist to further prognostication of the fatty liver disease and further management of the fatty liver disease. So only you can change your life, and no one can do it for you. And this is the last slide for me. And what fits your busy schedule better is exercising 1 hour a day, like around 60 minutes a day, or being there 24 hours a day. That uh, people itself has to decide. And the World Liver Day in the past one continues 2 years. The theme is on the fatty liver only. Last year also the theme is on fatty liver. Now also the same thing. The be vigilant, get regular liver checkups, and prevent fatty liver. This is 2024 theme. And tomorrow being a World Liver Day. So this is a theme which has been so. Fatty liver disease is a growing epidemic, and be vigilant on that. Thank you.
So, thank you so much, sir, for this wonderful talk. And this has really enlightened us on the all aspects of NAFLD and NASH. I think you covered almost all the points that are necessary that people should know about NASH and NAFLD. So, on behalf of NASH 24/7, sir, I thank you for this lively and informative talk and taking this initiative on occasion of the World Liver Day. And as you have been emphasizing the awareness for the liver health and disease, I think it's equally important for people affected by fatty liver to regularly visit and continue medications. With careful observation and precautions, it is possible to obtain control of the disease. I would also like to thank our audience for their active participation and patience in making this event successful. So stay connected with NASH 24/7 on Facebook and YouTube, and take care of yourself and your family members. Thank you. Thank you, sir.
Thank you.